Welcome, everybody. Today's speaker is Kishore Iyer. Dr. Iyer is a professor of surgery and our director of adult and pediatric intestinal rehabilitation and transplant. Mouthful. And so we're very pleased to have him speak to us today regarding that topic as it pertains to liver disease, as well as the dreaded complication of mesenteric thrombosis, which Tom and I shudder at. So thank you very much.
Thank you. Thank you so much, Gene. I'm delighted to be here. I was at a UNOS policy committee meeting yesterday and having some beer in the airport with a couple of the liver surgeons, and I was showing them this, and I said my role in this program is a little more, is less surgeon, more like being general foreman at the Jiffy Lube, and I feel like I know what the car needs maybe better than most. Perhaps that might be my only skill. But for the medical historians among you, this is actually the first, I love the cover of this book, and somebody actually gave me a print of it, but this is the first evidence of a formal description of the portal venous system. And you will see that, you will hopefully see, yes, you will see that Andre Vesalius got it pretty close. He got the portal vein, he got the SMV, there's a hint of a splenic vein, and if you imagine, I haven't read the original, but if you imagine, you can see that there might be an inferior mesenteric vein. For the purpose of this talk, just to set the stage, I'm not going to do a talk on surgical management of portal hypertension. I'm not talking of the vast majority of portal hypertension that we think deal with very well, both cirrhotic and non-cirrhotic. I have an interest in, that's how I came into this, I have an interest in non-cirrhotic portal hypertension and portosystemic shunting and the application thereof. But this is a dreaded problem for the patient and the carers. So for the rest of this talk, I'm really going to focus on what we call confluent portomesenteric thrombosis, and then variously we've called it splanchnic venous thrombosis, or complicated portal hypertension, and I'll allude to what I mean by complicated. But therefore I'm going to talk about occlusion in continuity of the portal superior mesenteric and splenic veins, and the consequences are somewhat easy to imagine. And so here's this sort of cartoon illustrates in very simple principle what is the technical problem. If you imagine a TIPS as a prototype portosystemic shunt, in this day and age perhaps almost the only example of a non-selective portosystemic shunt, you can imagine that in the cirrhotic patient with consequences of portal hypertension, a traditional TIPS would solve the problem of decompressing high pressure portal blood into low pressure systemic blood, and this then becomes self-evident that in the absence of any inflow, a traditional TIPS would not solve the problem. The challenge then is that there is no role for conventional portosystemic shunting in this situation. Just intuitively, portal hypertension and surgical management of portal hypertension requires good inflow, requires good outflow, and requires a shuntable vein, and that's a somewhat subjective term, but at operation, when you try to shunt even big caliber collateral veins, the vein quality is poor, difficult to accomplish technically, and we know now that long-term outcomes, even medium-term outcomes with makeshift shunts, as they were called, are really very poor. Therefore, and I put this up just to sort of give you a little list of the repertoire that is important for the most part only in its non-availability for this problem. Therefore, what is not feasible, the conventional distal splenorenal shunt, which is still the prototype selective portocable shunt, and for the fellows in the room, it's a surgical paper that today would not get published. It's a technical description from 1964, 67. If anybody's interested, email me. I have the original. It's just a good description of a good operation with a good basis, and that operation in over 50 years has not changed. And I had opportunity here at Sinai 3 times now where somebody told me, oh, I did the distal splanchnic shunt, and I always said, do you remember the last note of Dean Warren's paper where they said not only is it important to do the shunt, but it's important to ligate the coronary vein? The guy said, no, I had never done that, and said, I have had now a handful of times, 3 at Sinai, where failure to perform the last step as described by Dean Warren results in a patent shunt by recurrent bleeding. So it's a good example of a very well-written surgical paper that today would probably not see the light of day. And so also semi-selective shunts, mesocaval shunts, the more selective mesoportal shunt, which is very uncommon in adults. We've done a couple, and much more popular in kids, and then standard tips, as I said, would not be useful. If you can't do a portosystemic shunt in a patient who is being considered for surgical management of portal hypertension, the salvage procedures are usually devascularization procedures. And I crossed out simply devascularization, not because it can't be done, but because they're notoriously unsuccessful, being complicated by rebleeds. And we will talk briefly about the modified Segura procedure that we do. And then if we come to transplantation, intuitively, it's almost important to consider organ replacement for for a plumbing problem, for non-end-organ disease, but we are sometimes forced to consider transplantation both for cirrhotic and even non-cirrhotic portal hypertension, and most times an isolated liver transplant is not an option. I'm not sure where I'm meant to be pointing this, but nothing seems to happen. Okay, so the significance in the context of transplantation is that multivisceral transplant as the only option for this population is very problematic due to a few reasons. This population often, especially non-cirrhotic portal hypertension, has low natural MELD scores, and therefore in our region especially, but really throughout the country, multi-organ availability inclusive of a liver-containing graft is quite the problem. And while multivisceral transplant outcomes have continued to improve in the last few years, there is still very significant morbidity and even mortality associated with multivisceral transplant. Having stated somewhat emphatically that the role for surgery in portal hypertension is limited, I do want to illustrate that to mention a few principles. We know from our surgical experience in portal hypertension that emergency surgery carries a very high mortality, mostly due to hepatic failure. And for the most part, emergency surgery has been completely supplanted by increasing skills and techniques, both from interventional radiology and from interventional endoscopy. And we're fortunate here that we have advanced techniques in both. We have most recently, actually, we had an example of a child that I had done a Kasai on for biliary atresia, and he now presents 9 years later, cirrhotic, well-compensated cirrhotic, but with all the complications of portal hypertension, came in emergently, massive bleeding. We were able to control his bleeding with BRTO, and in the same admission about 7 to 8 days later, I did a distal renal shunt, and he's now, again, about a year or so out and doing well. So emergency surgery should really have almost no role in this day and age. Elective surgery is mostly effective in preventing recurrent hemorrhage, may restore normal physiology, and I'm going to speak about this a little bit, and then correct secondary complications in some cases. So the choice of surgical shunts, one should think about selectivity, non-selective. I sort of mentioned this in passing, but really you all are familiar with the complications of non-selective shunts as manifested in a wide bore tips, in a somewhat in a marginal liver, and today the surgical portocable shunt is hardly ever done, and at the other end is the super selective distal splenorenal shunt, and the idea simply is that it's only a fraction of portal blood that is being diverted away from the liver, with mesenteric blood flow through collateral still being preserved towards the liver, which is why a distal splenorenal shunt would be preferable from a selectivity point of view. Patency, large bore shunt, a portocable shunt with a large portal vein anastomosed to the cava might carry greater patency, and then when you talk about a mesocable shunt where you often need a synthetic graft, therefore long-term anticoagulation, patency rates drop. And then we have to talk about the complications of encephalopathy and rebleeds. I mentioned this in passing years back before we did a better job as we do now with the multidisciplinary team. In some desperation, I've done a small number of these shunts, mesoatrial shunts, which you probably will not find in the literature. Some use in historical reports of Budd-Chiari syndrome require long-term anticoagulation. And you need, if you think about an anastomosis between the superior mesenteric vein and the atrium, you need a very long graft of prosthetic material. So in this day and age, there's a series from Portland, Oregon, where they've used this exclusively in Budd-Chiari and compared two small series, not controlled, but they suggest that a mesoatrial shunt is mostly replaced by a combined mesocable shunt with a cavoatrial shunt with some reasonable medium-term outcomes. But just to tell you what the magnitude of the problem is, this was actually a patient I looked after here, a 15-year-old Pakistani girl several years ago, who came to us with complete Splanchnic thrombosis, unknown etiology, referred for liver transplant, referred for multivisceral transplant with a bilirubin presentation of around 13, hypoalbuminemic, a lot of ascites. But during our investigation, she looked a good candidate for multivisceral transplant, but during her workup, it appeared that she had peritoneal TB. So, accepting that multivisceral transplant was a bad idea, I did a mesoatrial shunt in the hope of meaningful palliation, and that's a frightening picture to me even today, that we're looking at the we're looking at the sort of intradiaphragmatic liver there with the shunt going towards the atrium. And here's what happened. You can see the length of this graft in this case going all the way from the SME to the atrium, and what happened was she was non-compliant with her anticoagulation. At 2 years, when she thought she was doing very well, against my advice, she went to Pakistan for a wedding, and I said, okay, then if you have to go just for a week and come back quickly, don't forget your Lovenox. And she actually was brought in moribund from JFK to our ER 2 months later, having run out of Lovenox, and you can see what happened. So, unfortunately, she died of massive, uncontrolled bleeding that we were not able to control. So that operation, I think, should be gone. I want to mention this because it's interesting from a physiological perspective, and because I do think there may be selected patients with complicated portomesenteric thrombosis that extends into the superior mesenteric vein who may still be candidates for this operation. This operation was first described in children, and actually in its first reports by Jean de Villedegoyer from Belgium, it was actually used in late after live donor segmental liver transplant with portal vein thrombosis. And the idea, so the rex recess is the entry point for systemic blood flow to the body in utero, and as most of us know, there's a segment of umbilical vein that remains patent for life and technically can return blood flow to the left portal vein. So at least in children now, this has become optimal option in extrahepatic portal vein occlusion, and I've now had at least 2 cases where we've used this operation in older children who had proximal SMV occlusion. It does make for a slightly more difficult operation, but it's doable. This was from Ben Schneider, some of you may know, ex-Sinai. What I call, this is the child of Venous. So at Venous in Italy, there's a consensus conference on portal hypertension, and a satellite conference of that is the Pediatric conference. I call it the child of Venous, and this was their last recommendation, and basically this illustrates the principle of the so that's the embryologic basis of the Rex recess, and the left portal vein in the older child can be accessed by following the umbilical ligament. And that's what the completed mesoportal Rex bypass looks like from the superior mesenteric vein to the intrahepatic left portal vein in the Rex recess of the liver, which is easily accessed by following the umbilical ligament. And this is an intraoperative picture of a patient I did a few years ago. After some misguided attempts, I now mostly use the left internal jugular vein, which is what you see there. This is now the Rex recess, and you can see there's what's left of the falciform ligament, and you can see it's a pretty deep dissection to expose the left portal vein. You can't quite see it so well, but there's a vessel loop around the left portal vein, and you can see patent tributaries going into the left portal vein, which we try and preserve and do anastomosis as close to maintain outflow as possible. So at this end, while you don't see here it's coming off the SMV, you can imagine if you have a segment of SMV that is open further down, you can access it and restore flow to the liver. So this is what that looks like late and both in cross-section and coronal view. And while that looks like there might be stenosis there in that particular case, we interrogated it and decided it was not stenotic. That's an early picture, and it was fine that patients not needed reintervention, even though there's about a 25-30% need for reintervention in these patients. And the beauty of this, of course, as you can imagine, is you've restored in the presence of portal vein thrombosis, you have restored intrahepatic portal flow. I don't know that you can see this very well. We can move on. Take my word, it's patent. And this was a nice paper in 2006 looking at late benefits of the mesoportal bypass. And these are some neuro-cognitive tests in pediatrics, getting to the point that while we have often believed that loss of portal flow to the liver, it has only plumbing consequence, no functional consequence, at least in children. There appear to be clear neurodevelopmental consequences. And in adults, it is easy to see that the occluded portal vein may be associated with encephalopathy in certain situations. You were going to ask a question.
What's the sort of clinical indication for this kind of Rex procedure?
I'm going to come to that. Okay. They've gone on to suggest preoperative anatomical prediction of likelihood of success, and it's easy to see that if you have good intrahepatic portal anatomy, which is often the case even in the presence of extrahepatic portal vein occlusion, that you may have this anatomy, intrahepatic portal vein and its radicals are open, despite the main portal vein being gone. And while we try and predict this preoperatively with CT venogram, especially in children with isolated extrahepatic portal vein thrombosis, I would today still explore the Rex recess, find the intrahepatic left portal vein, if necessary do an on-cable angio to see if anatomy is favorable before completely abandoning that as a choice, even in preference to a distal spleen renal. So I would do the trial dissection before abandoning it and go to a distal spleen renal for isolated extrahepatic portal vein occlusion. If I don't, I thought I had a slide about indications. If I don't, well, I'll answer it. So the outcomes are pretty good. Approximately 85% of children with extrahepatic portal vein occlusion treated with the mesoportal bypass remain bleed-free. I said 25%. I do think it's 25%. 15% at least or so require some postoperative percutaneous venous dilatation to maintain patency, but that's easily accomplished. It's a relatively low. And there have now been several studies showing objective decreases in spleen size over time, improved platelet counts, and improved neuro-cognitive functioning after the mesoportal bypass. I didn't have a slide. So the indications for the mesoportal bypass are no different than the indication, say, for a distal renal shunt in a child with extrahepatic portal vein occlusion. The Baveno Consensus Conference accepted that there may be a relative indication in two scenarios, and that's not very different, I think, from indications for surgical intervention in these patients, the child living somewhat remotely away from a major transplant or surgical center. That's number one. Number two, now, there are two pieces of evidence. One suggesting that medium to long-term patency of the mesoportal bypass and even feasibility of doing the operation, the mesoportal bypass, might be better in the younger child. As time progresses, there is fibrosis, there is the consequences of obliterative portal venopathy, and the success of this and the ability to do this in the older patient, older child or young adult becomes more difficult. Therefore, the ability to do this and restore portal flow might be better earlier you do it. So that becomes a relative indication, even in an asymptomatic child with extrahepatic portal vein occlusion. And the second, and this is now still in some evolution, but there seemed to be clear objective evidence of improved neurocognitive functioning by restoring portal flow to the liver. So that's obviously a tough sell, and you manage expectations carefully. Every hyperactive child with extrahepatic portal vein occlusion doesn't start to function perfectly after the operation, but that becomes a relative indication. So as most of you know, certainly you did when you're thinking of, in this case, a cirrhotic liver at the time of transplant, you perfuse the transplanted liver on the portal vein, and typically the way it's done, you do the outflow vena cava, whether it's the standard with caval replacement, suprahepatic cava and intrahepatic cava, followed by the portal vein, or just the suprahepatic cava if it's piggyback and the portal vein. You reperfuse the liver on the portal vein, and then once you control bleeding, patient stable, you do the hepatic artery. But what that does require is that the donor liver comes with the portal vein segment, and at the recipient end, after the hepatectomy, you clamp the portal vein, and you need the recipient portal vein to be open and provide portal inflow to the transplant liver, which you can see in this case, in a case like this, with an occluded portal vein, an occluded SMV, and an occluded splenic and IMV in this case, it's not possible. So that's the idea of a normal liver transplant. So what are the options when there's more extensive portal vein thrombosis? If there's liver cirrhosis with complete portal mesenteric thrombosis and therefore no available portal inflow, one option is portal caval hemitransposition. As you can imagine, in this case, the lower cava is tied off here, and the infrahepatic recipient cava is anastomosed to the donor portal vein, and that's what that picture looks like. The slide was generously shared by Jan Moon, because he was one of the co-authors of this 10-year experience reported from Miami, using portal caval hemitransposition in the presence of portal vein thrombosis. Keep in mind, just want to go back 1 second to this slide. Keep in mind that even if you have extensive portal vein thrombosis and the superior mesenteric vein is open, the preferred option would be to declot the portal vein if possible, and it's surprisingly possible in most cases. And if that fails, to put a jump graft to the superior mesenteric vein close to the confluence and bring that to the portal vein. So we're talking portal caval hemitransposition only when the portal vein thrombus is extensive and appears to extend well into the superior mesenteric vein. But you can see here that even in terms of patient survival, by about the, whatever that is, 5-year mark, 3-year mark, survival has dropped to about 42%. And having looked after a few patients with portocable hemitransposition over the years, I've been impressed that it's an operation that results in pretty significant morbidity for a somewhat extended period of time with lower extremity edema and poor liver function even otherwise. So even beyond the survival that is not the greatest, at least my own bias is that I haven't seen one done, but my own bias is that this does not seem a very good option. So the other option is to transplant the liver with the portal-mesenteric system. What if you brought a liver with all that? In fact, in some ways, if you think of the same patient with extensive portal-mesenteric thrombosis in the face of non-cirrhotic portal hypertension and life-threatening bleeding, in some ways what we're talking about is why not we just transplant the portal-mesenteric venous system? So you could transplant the portal vein, the superior mesenteric vein, the splenic vein. One little matter of detail, the only way to do that type of transplant is with the organs attached to them. So that's how we come up with the idea that a multivisceral transplant is an option for this problem. So the only real paper looking at outcomes for multivisceral transplant, and this is the group with the most experience in this operation at Miami. There are several programmatic and logistic and organ allocation reasons why they have this experience, but they reported 23 multivisceral transplants. This was from their time in Indiana, though the practice is not much changed or different between Indiana and Miami now, but they reported 23 multivisceral transplants with 1-year patient survival that was pretty good at 80%, and they suggested that non-cirrhotic patients especially would do well with this. Anatomy was favorable because you could treat the combined liver, bowel, pancreas as a single organ, making the organ eviscerectomy, if you like, somewhat easier by treating it as a single organ. Of course, there are issues of is this the appropriate use of organs, and it's certainly still a very high-risk procedure when you look at it from the perspective of liver transplantation. I just noticed that this is there. Do you mind if I take a quick sip while you take a breath and I'll take a breath? Sorry. So, oddly enough, and for many of you this will make intuitive sense, a multivisceral transplant, a different way to look at it is that all small bowel transplantation, in fact, needs to be viewed in the context of composite visceral grafts. So I was telling somebody recently in a lay presentation, this is like driving through McDonald's. You can buy the regular, you can buy medium for $1 extra, and just one more buck, and you can supersize it. It amazes me that you cannot go to a movie house now and order a popcorn without them telling you, do you want to pay 99 cents more and get medium? No, I know exactly what I want. And you've helpfully put up the calories there for me. But anyway, so this is one way to look at intestinal transplantation in the context of a composite graft, and so when I look at this problem from the point of view of intestinal transplantation, we have a patient who comes to us referred for intestinal transplantation, whether that started with intestinal failure or at the other end, your type of patient with complicated portal-mesenteric thrombosis. I would still look at it from here. What is the choice of graft? How would I decide what the graft is that is needed here? And that really depends on anatomy and pathology. You could start with an isolated intestinal graft that is pedicled on the superior mesenteric artery and the superior mesenteric vein. We now routinely add the colon. We've now been doing this for about 5-6 years. We just recently looked at it for a different report that's actually just coming out this month in transplantation. We've done over 60 or 70 intestine transplants, now all with right colon. You can do it with the pancreatico-duodenal complex. You can include the stomach if you so choose, and you can do that with or without the liver. So it's really, and for obvious reasons, it is correct to view this with the intestinal graft at the center, because unfortunately that does appear to drive both the complications, the need for immunosuppression, and ultimately the long-term outcome. This is not new. Dr. Starzl, now the late Dr. Starzl, who pioneered so much in transplantation, early on in his experience likened the abdominal organs as being like grapes on a vine, and when in the context of multivisceral transplantation, you look at each of the vines as providing the vascular basis for the graft of your choice, so that you can pick and choose whichever grapes you want off this vine. And so you can see that that concept is very valid even today. And so the full multivisceral graft really contains everything in that picture. And just to bring us back to the topic we're discussing here, even in the case where all you wanted to do was to transplant the splanchnic venous system, you could do it. Unfortunately, the organs would have to be attached to it. A few quick slides just to give you some idea of what are we looking for when we are thinking of a multivisceral transplant. We need compatible AVO, not much different from liver transplantation, and size sometimes becomes tricky for us, because in fact the paper that we have just coming out, it has a somewhat provocative, is what I hoped, title that small for size syndrome does not occur in intestinal transplantation in the absence of liver containing grafts. And we now know that to be true. We've transplanted several adult patients with infant grafts and donor recipient weight ratios well below 50%, and in the most extreme below even 30%. So we've used 1-year-old, 2-year-old bowel donors for adult recipients with excellent medium term at least function. So over the last 5-6 years we've been doing this. That paper is just coming out, but the interesting thing is you then and that has come about because most patients with intestinal failure have had many operations. They run out of space, they lose abdominal domain, and so you need a smaller graft, you need a smaller donor to accommodate the intestinal graft. But then we know, of course, the consequences of small for size in liver transplantation. So we settle in the multivisceral graft, we settle for as close to the lower end as we dare, and that's often between 50 to 60% of recipient that we will take, because that seems to be what we need to get the belly closed and to move on. And that's how the donor operation is done. And just in principle, this is true for any organ. The principles of obtaining deceased donor organs is very, very simple. You have to replace the organ of interest. You have to replace the blood in the organ of interest with a cold perfusate that has preservative qualities, and you have to vent the blood. So as you can imagine, depending on the organs you want, you then take, if all you're interested in is the kidney, that's where you take it. If you want the kidney, intestine, pancreas, that's what you take. If you want the multivisceral graft, this is what you take with venting the blood in the suprahepatic cava or from the right atrium. We have been now for the last 5 years or so looking very closely at lymphocyte cross-match. There does appear to be some evidence of importance of the presence of preformed antibodies, at least in isolated intestine transplant, even less clear in liver-containing grafts. But of course, you all know of the emerging evidence that maybe medium and long-term function may be affected by preformed antibodies. So we're looking at this information in the context of liver-containing grafts. We're not certain what to do with that information. So that dotted line would then represent a multivisceral graft, but you can see easily we can move the dotted line if we wanted to include the kidney. We can shorten it if we don't. That's what a graft looks like. This is from many years ago, but that's what a multivisceral graft looks like on procurement. There's the stomach, there's the spleen on the left, the liver. So this is the pancreaticoduodenal complex, entire small bowel. You can see that was in 2002. But now we would include the right colon. So that is the right colon, right transverse colon. The idea is still vascular. The basis for what you keep and what you can't is vascular. So because the right colon is supplied by and drained by the midgut vessels, we can still keep the right colon. And on the back table, we would remove the spleen, we would remove the gallbladder, and that whole thing would go in. And I tell everybody this is an uncommon sight even for experienced surgeons. There's really nothing in the abdomen. There's a clamp across the base of the heart. And other than the retroperitoneum, the kidneys are there. But the fact is you didn't include the kidneys too. And that's what the abdomen looks like after operation. But to get to this point, especially in the patients with complicated portal-mesenteric thrombosis and portal hypertension, that can be a bloody tour de force to get to that point. Some outcome data, and you can see that there's a problem with doing this routinely, because as intestine transplant outcomes steadily improve, you can see this is already older data. For patients with liver-containing grafts, you can see 5-year outcomes of about 45%, not great. Younger patients maybe do slightly better. Younger patients without the liver do better. I will tell you that our own isolated intestine transplant outcomes right now, we're reporting between 92 to 94% 1-year survival. All comers, we're reporting this year, we're going to report 83% 1-year survival for all comers. So 5-year survival, it's not fully caught up, but we're on track to be reporting between 60 to 70% 5-year survival for all comers, which even 5 years ago I'd have thought not possible. So it's starting to get better. I think to some extent this is a reflection of the small numbers, but that does tell you why efforts to try and prevent the need for multivisceral transplant are certainly appropriate. So some years back, Tom and I got together with Rob Lukstein from Iyer, and this was not an aha moment, it was an aha several months, that we realized that each of us had an interest in this problem. We were seeing a few patients here and there, and we were sort of on an ad hoc basis, conferring, getting people together. There was a lot of effort, and a lot of credit to Tom for doing the initial legwork to say, let's all try and meet and formalize this a little bit. Tom actually cobbled together a web page saying that here's our shingle, have portal-mesenteric thrombosis, find us. And I will tell you, I've railed against how bad Sinai's online presence is. That one web page that Tom put together has probably been the single most effective marketing tool I think we've ever had. Maybe Tom should take over Sinai's web presence. We might do better. But this is, some of you may have seen this, and this is already actually, this data is outdated, but Alyssa Birmingham, our indefatigable PA, presented this data at our international meeting last year in New York that I had the privilege of chairing, and we just looked at 20 consecutive patients that we've looked after in this multidisciplinary approach. So we had 20 patients with confluent portal-mesenteric thrombosis, and you can see it's a long time. The first couple patients were early, then we kind of brought and formalized it, and that's what happened. So all of them were adults. 7 of the 20 were cirrhotic, so you can see 13 non-cirrhotic, and if we had only multivisceral transplant to offer them, that would have been challenging. But this was interesting to us. Identified hypercoagulable states, only in about 2/3 of them. 3 of them with acute presentation. I'll refer to that briefly. Some had refractory GI bleeding. We're seeing this more and more. Patients with portal-mesenteric thrombosis or isolated SMB thrombosis who present quite dramatically with postprandial pain. So one of the things I didn't mention earlier, but it seemed right to do it in this context, is I've had an interest in this operation for some time, and it's very difficult to get a good operative picture because when I first told Myron that I was going to do this, he said, "Oh my God, that's the most mutilating thing I've ever heard." And I wanted to say, Myron, hear yourself, for all the things you do and for all the things I do, why is this mutilating? But I will tell you that nobody in the West has significant experience with this operation. Tremendous experience in Japan. They've reported several hundred cases, tremendous experience, surprising outcomes, and I will tell you why. It has nothing to do with the quality of the surgery. But so here's actually, I follow the original description of this operation. I had the good fortune when I was doing pediatric surgery in London to work with somebody who was interested in full hypertension, and we, in rapid succession, when the early reports of the Segura procedure came, we did that in half a dozen kids. So that had been my only exposure to this operation, but I was impressed that it seemed to temporize well. So the first time I did it as an attending was at Children's Memorial in a 6'6" firefighter from Indiana who had seen in Omaha, he'd been referred for multiple transplant. Indiana had said to him, "You're portal-centric thrombosis, so what if you're not cirrhotic? There's nothing else to do." I've seen him in Omaha and I said, "That's ridiculous. You're not cirrhotic. We should be doing something else." And when I moved to Chicago, they found me and they decided. So he's the first patient I did. He's actually alive, well, bleed-free with his native organs now. So I've been out of Chicago for almost 15 years from when I did his operation. So this is what it contains. I do a splanectomy, I do a devascularization of the lower esophagus, 8 to 10 centimeters, as recommended originally by Segura. Then I do a devascularization of the superior 2/3 of the stomach. And this is the step that frightens most people, I transect the lower esophagus and reanastomose it, and then I combine it with a pyloroplasty in most cases. The basis for that is very simple. It is really that the idea in Segura's original paper is that when you think of portal hypertension from a teleologic perspective, what you see are collaterals in the different parts that are occluded. And the thinking behind this operation was that most collaterals actually serve an important physiological purpose of returning blood to the heart. And if you want to give it a quantitative sense to give you some idea, so in a case like this, 98% of the collaterals are serving important physiological purposes. 2% of the collaterals are offending and causing problems by bleeding. So Segura said, let's just deal with those 2%. So deal with the varices directly around the stomach. If you take away the spleen, you get rid of the short gastrics. You do the same with the lower esophagus. And this is where the transection of the esophagus comes. When they early on did it without esophageal transection, there's a lot of published experience from Japan with just esophageal and gastric devascularization. They realized there was a high rebleed rate, and Segura came up with the idea that the rebleed occurs because there are longitudinal venous channels in the wall of the esophagus that contribute to rebleeding, and the only way to deal with them is to transect the esophagus. So I faithfully follow this. I haven't suffered. I've had one young teenager, I did a 13-year-old several years back, who did develop an esophageal stricture that required repeated dilatation over about a 1-year period. All of the adults have done very well, and I'm going to show you the data we looked at in this cohort, though I'm now up to about 22 or so Seguras without bad outcomes. So this is what the Iyer folk are able to do. I'd be very sad. Oh, there is a video that I can show you. But what they're able to do, several years back when we sat down and talked to Rob and crew about this, I said, look, I'm seeing reports of transplantic access to the splenic vein and the portal vein. Why can't you do that? Rob first thought I was crazy. So the first case we did, we actually booked a patient for a Segura so we could keep an OR. And because for Rob to think somebody else is crazy, those of you who know Rob Lookstein, for Rob to think that somebody else is crazier than he is saying something. But nevertheless, that's how we did it. And of course, those of you who worked with our interventionalists know they're technically just superb. And basically what they do is they're able to place in the patient's portal mesenteric thrombosis, they're able to place a catheter into the intrasplenic vein through a transabdominal approach, and hopefully I can show you this, and then shoot venograms, and you can see that there's a, that is such a pity. That is such a pity. You would have seen some cool stuff, but that I can't take credit for vicariously out of. But nevertheless, what they're able to do is to go through the splenic vein, shoot a venogram. You can get the arterial phase and get venous phases, and now they have splenic vein access. I'm going to keep trying though. Oh, none of the codec is unavailable. Okay. And then what they're able to do is to recanalize from the splenic vein into the superior mesenteric vein. And this is such a pity, but luckily I do have some stills, and they are, in this particular case, they recanalize into the right anterior portal vein, and this is a very cool stuff. But it's not going to show you. But what they do now, and this is an important principle, so they have jugular access into the hepatic vein, to the right hepatic vein. They have transplenic access sometimes to the end of the splenic vein, sometimes with luck into the portal vein. They then percutaneously thread a needle through these two loops, exchange the needle for a catheter that is then snared and pulled up into the neck, and then it is snared through this loop out through the spleen. So this is then converted into access that comes out through the spleen and out through the neck. I tell them if they could only see what they're doing, they would all need therapy. They would probably all need therapy anyway, but that's a different matter. Okay, that's also unavailable. And then you end up with an extended tips that I don't know if you can see it, but you can just about see that tip starts there, coming up all the way up to about here. It ends here, I can see it here. So they're able to do this now in an increasing number of cases, and actually they have now done 3 percutaneous mesocaval shunts. I didn't have the pictures, but you can see the idea, the concept is the same. They get in somehow through the splenic vein, into the superior mesenteric vein, they get into the cava, and they percutaneously puncture between a big collateral of the SMV. And while I'm a little concerned that these are not true mesocaval shunts, they're collateral mesocaval shunts, and those, at least surgically, those outcomes are not very good. We were just talking that maybe we're ready to report this. The first of these cases was done at 3.5 years and is still patent. So this is what this cohort looked like. Oh, I didn't realize that the arrows were there already, but we started with 20 patients with confluent portomesenteric thrombosis. 13 of them underwent percutaneous procedures. In this cohort, there were 7 Seguras. We excluded the multivisceral transplants from this analysis, and so there were 10 extended tips of the type I showed you. There were 3 percutaneous mesocaval shunts, and you can see that this is a complicated population. And clearly success should be defined in a very guarded fashion. Out of the 13, there were 3 rebleeds. 7 of them needed reinterventions, but 11 of the 13 are alive. I'll mention the other 2 in a moment. And of the 7 Seguras, 1 had a rebleed, 1 needed reintervention, and 5 of the 7 are alive. And the oldest patient that I did here is a corporate lawyer whose only concern, he would bleed every 6 weeks, but his only concern was whether if I did this operation, would it affect his golf swing. I'm happy to say his swing has not been affected, he has not bled, and he gets an annual endoscopy to look for varices. So 16 of the 20 are alive with medium-term follow-up, actually. The longest of them is at about 10 years, but most of them are biased towards the latter 7 years of this experience, so which is pretty good, I think. So I'm going to stop there and take questions. I'm really disappointed that I couldn't show you the videos. But our experience suggests that non-transplant interventions are a viable option for patients with confluent portomesenteric thrombosis. In our cohort, all patients in this cohort avoided multivisceral transplant with excellent medium-term outcomes. So you can see Benicio, I excluded the patients who went on to multivisceral transplant straight away, and I can tell you how we came to those decisions. This next conclusion needs to be viewed with some caution. None of the interventions, at least in principle, preclude future multivisceral transplant, but I will tell you that one of the early patients that we did in this experience with Iyer had come to us for a multivisceral transplant evaluation. We evaluated him, non-cirrhotic portal hypertension. We said we shouldn't do a multivisceral transplant, low MELD. We said, look, how about we will evaluate you, we'll close the evaluation as too early for transplant, and we will attempt the extended tips because you have nothing to lose. If that fails, if that succeeds, you avoid transplant. If it fails, we'll get on to multivisceral transplants. Unfortunately, the extended tips were successful but was difficult. And a couple weeks after his extended tips, he started having repeated fevers. And ultimately, we concluded that he had an infected tips. He had an infected tips with refractory fungemias and was very sick. So we had a Pyrrhic victory. He had solved his portal hypertension, but he had refractory fungemia. And the only way to remove the tips, obviously, was to transplant him. Very low MELD. We appealed to the IRB for a MELD of 40. Saying we are not going to get a window where he's not infected long enough to transplant him. We got our MELD of 40, but he never actually cleared his fungemia enough to. So he died. That was one of our deaths and one of the 4 patients who died. So we do think that rapid access to multivisceral transplant may be critical to long-term success with this approach. And I didn't share it. That data is already so outdated. I think now several of you, Priya, Tom, Jean, Carissa, I saw Jim somewhere, we've been seeing so many of these patients. We're now accruing patients. We're accruing between 2 to 4 patients a month. So this is already outdated. And I'll tell you, this is a good example of you build it and they will come. Because what amazes me about what I've just shown you is, if you think about it, most liver transplant hospitals actually have all of these abilities. Maybe not multivisceral transplant, and that provides a safety net for us. But most of them have these abilities. But we've now treated patients from Texas. We've treated patients from Arizona. We've treated patients who are seen at Mayo Clinic, both in Minnesota and in Arizona. And I sometimes think, wait a second, you actually can do this, but I don't know who to call. And if I don't know who to call, obviously the patients don't know who to call. So this is growing. It's almost ready to be reported, but we're all preoccupied with other things. Happy to take questions. There are my acknowledgments. I will say this is though it's a small number of patients, it almost is a labor of love because it's so painful to get the reports, get the records beforehand, and I asked Alyssa to come, but she was seeing patients in FPA. Alyssa is our coordinator, many of you know her. She's just, I can't tell you enough how much effort it takes to collate all the records and pull people together who are busy in their own worlds. Thank you.
That was great. Questions? Indra?
Very interesting. I just was very interested by the grapevine analogy, and one of the questions I had was, if you...
What wine do I like?
If you include, if the small bowel is transplanted along with its brethren, does it do better than...
Oh, yeah, that's a great question. That's a great question, actually. And I'm going to, if you will allow me, I'm going to sort of paraphrase the question a little bit. If you do patients do better if you transplant the small bowel with the liver? We don't care about pancreas. Don't tell anybody if somebody's interested in pancreas. But really, it's the liver that matters to all of you. I think the small bowel is more important. It's not just bile acid salvage, and portal flow, but I think the small bowel is important. But nevertheless, so there is actually evidence that patients with that transplants with liver-containing grafts do better in the long term. And that's not a very big leap of faith. If you look at it, if you compare liver kidney transplants with kidney alone, the incidence of rejection is much lower in the liver kidney transplants. But even that data is somewhat instructive, and I'll come back to that in a second. If you if you look at and the science is way beyond what I understand, but at least in simple concept, if you imagine that the liver is in some fashion an immunological sponge and modulates the immune response, it's easy to see that liver-containing grafts will do better. So when we look at our patients who have had multivisceral transplants or have liver-containing grafts, they certainly have fewer problems, even with the intestine, and their immunosuppression tends to be lower than with isolated intestine. But here's the dilemma that most of these patients tend to have low MEL scores, because if you now forget portal hypertension,
so you're saying they can't compete.
They don't compete, and they don't compete very well. If you forget portal hypertension for a moment, and if you look at the intestinal failure patient on TPN who starts to have progressive TPN-associated liver disease, the usual stigmata of end-stage liver disease that contribute to a higher MEL score are very late pre-terminal features in the context of TPN liver disease. So by the time you get hypoalbuminia, by the time you get coagulopathy, you're pre-terminal. And if your MEL score, if you need a combined liver intestine transplant or a multivisceral transplant with a natural MEL score in the high 30s, you are very, very sick.
So it seems that you would.
One last question, Andrea, for that. So some years back, and it was interesting, I was at UNOS yesterday, and there is a move that this should be now made public. But several years back, Bob Miriam shared with me a slide from SRTR, which actually looked at mortality on the waiting list for intestine transplant, combined liver intestine transplant. And we knew at the time, John Fryer, my colleague at Northwestern, has published on this, and there have been several iterations of revisions to the MEL scores to give patients with multi-organ listing some prioritization, but not enough. If you still look at the mortality on the waiting list for patients awaiting combined liver intestine, the young adults, it's a bimodal mortality chart. Very small babies have a higher mortality, but the young adults, the older 18 to 30-year-olds who are competing with the bulk of adult liver recipients have about a 28 per 100 patient years waiting mortality on the waiting list, much higher than any other organ group. Right? So Bob Miriam actually analyzed the data on an intent to transplant basis. So if you just look at long-term outcomes for isolated intestine, combined liver intestine, the graft survival, not so patient survival, graft survival is superior for combined liver intestine. But if you do that on an intent to transplant basis, the grafts are reversed. If transplant were a research drug and you said intent to treat analysis, then there's about a 25-30% mortality on the waiting list on top of everything else. So that's why those patients, I think, do worse, unfortunately. We've had some luck. Some of the OPOs seem to exercise their discretion to allocate organs in preference to a multi-organ graft, but not yet.
I think we'll have to end here, so if you have any further questions, come up to see Dr. Iyer. Thank you again.
And I can hang on. Thank you. Sorry.